Good evening, fellow interns. Here we are up with another therapeutic presentation session. We will be continuing with the neurological department today. Hope I am audible. Could anybody just reply?
Yes.
Okay, thank you. So today, we'll be, as I said, we'll be continuing with the neurological department. Today, we'll be dealing with two topics. One is with the Alzheimer's, and the other is with Parkinsonism. So we have four presenters today. Four presenters today. One, Alzheimer's disease will be dealt by Panugotu and Badal Chowdhury. Both are from family third year. And Parkinsonism will be dealt by Nitisha and Safia. So Safia will be dealing with the case presentation part. So I'll just brush out the rules and regulations for y'all. As y'all know, each presenter will get 25 minutes to present their presentation. Later, at the end of the session, we'll be having a post-session Q&A. So feedback form and the post-session quiz will be shared in the chat box later on. To make the session interactive, I kindly request everybody to be interactive and post your queries in the chat box. Relevant to the topic. And then yes, even if y'all want, y'all can even unmute yourself and then ask your queries. I request y'all to unmute yourself later during the post session Q&A. So now I call upon Badal Chowdhury and his co-partner to start the presentation. Thank you. Is Badal Chowdhury present? Yes, Badal Chowdhury, I think you can share the screen and start your presentation.
Am I audible? Hello.
Yes, you're audible.
Good evening, everyone. My topic is Alzheimer's disease. I am Badal Chaudhary from family third year. Uh, Alzheimer's disease. First of all, we will talk about dementia. Dementia describes a clinical syndrome characterized by a significant deterioration in mental function, leading to impairment of normal activities. In healthcare, normal function is measured by activities of daily livings. These routine activities should be performed independently and are divided into personal tasks and domestic tasks, which include washing, dressing, toileting. Wait. Is it okay now? Okay.
Yes.
Washing, dressing, toileting, continence, and transferring. Domestic tasks include cooking, cleaning, shopping, managing finances, and taking medications. In that picture also, we can clearly distinguish between the normal brain and Alzheimer brain. Alzheimer brain is shrinked, and the normal brain is just in normal position. That is there is no shrinkage in normal brain, while the Alzheimer brain is having shrinkage that will be leading to the decrease in function of the brain activities. Now, dementia can be caused by several conditions, which all manifest with poor mental performance and impaired normal functioning. The clinical manifestation of dementia can reflect the underlying etiology. Uh, in dementia, there will be certain diseases which will which will contribute. Uh, Alzheimer disease will be in 50 to 75 case 50 to 75% case of dementia, there will be the chances for Alzheimer disease. Vascular dementia 20%, dementia with Lewy body 15 to 20%, front temporal dementia 2%. Rare causes are also seen in dementia, mm, such as Parkinson disease, dementia, Huntington disease, and prion disease. Now, Alzheimer disease, the simple definition of Alzheimer disease is it is a progressive neurodegenerative disorder that causes significant deterioration in mental performance. This leads to impairment in normal social and occupational function. It is the most common cause of dementia and unfortunately an incurable condition that has a variable clinical course. Now the epidemiology of Alzheimer disease. The World Health Organization estimates that almost 50 million people have a diagnosis of dementia worldwide. In UK, it is estimated that more than 5 lakh people have a diagnosis of Alzheimer disease. The prevalence of dementia increases with age. That is, the person having age of 60 to 64 years, there will be chances of 0.9%, while the person who are having the age of more than 95, there will be chances of 41.1% uh, of occurrence of Alzheimer disease. A significant proportion of patients with dementia remain undiagnosed, and up to 54% of patients with dementia require care home placement. That is, they need special care from the home itself. We can also see the graph of epidemiology from time to the number of patients. That is, in 1990, there will be approximately 4 lakh peoples, and the trends are increasing up with respect to the population. Now, etiology. There are various causes for the occurrence of Alzheimer disease. Major causes genetics. In genetics, there will be mutation in APP, PSEN1 and PSEN2. APP stands for amyloid precursor protein, and PSEN stands for presenilin genes. These are the biomarkers uh, that are responsible for the uh, detection of the Alzheimer's disease. When there will be the genetic mutations in APP uh, and PSEN1 and 2, they will cause the early onset of Alzheimer disease. Polymorphism of APOE is also responsible for the occurrence of this disease. This allele increases the risk of developing late onset of Alzheimer disease. APOE APOE stands for apolipoprotein. It is the strongest risk factor for the Alzheimer disease. Am I audible?
Yes, you are audible, Badal. You can continue.
Okay, okay. Uh, the other factor is environmental factor, which include tobacco smoking and pesticides. Exposure to tobacco smoking is a known risk factor for Alzheimer disease, while the certain pesticides have been implicated in the development of this disease. There are also certain metals o- in which in which includes arsenic, lead, copper, mercury. Exposure of these metals uh, has been linked to increased risk of Alzheimer disease. There are also chances of getting this disease from the various cardiovascular diseases, which includes hypertension, heart trauma, and diabetes. Hypertension and diabetes are both related with stroke. That is that is when there is stroke due to these diseases, it can lead to the dementia, because there will be the reduced blood flow in the brain, which stops the brain cells of the oxygen, and will lead to the impairment in normal functioning of the brain. History of head trauma can increase the risk of developing Alzheimer's disease. Aging free radical generation. Uh, the aging process is associated with the generation of free radicals, which can contribute to the development of Alzheimer's disease. Free radicals can cause oxidation of proteins, which can affect neurons and glial functioning. The pathophysiology of Alzheimer's disease. First of all, there will be the formation of amyloid plaques, extracellular deposits of amyloid beta peptides aggregates to form amyloid plaques. Amyloid precursor protein is cleaved by enzymes. Amyloid precursor protein is cleaved by enzymes, leading to the formation of amyloid beta proteins, which is neurotoxic. Uh, Amyloid precursor protein are being cleaved into the amyloid beta proteins, which are responsible for the Alzheimer's disease. Then neurofibrillary tangles, intracellular aggregates of hyperphosphorylated type tau proteins. These tangles disrupt normal function and lead to cell death. Tau proteins are these are the proteins which are responsible for the structure of cells, normal structure of the cell. When these tau proteins are twisted, they cause uh, they cause the they cause the s- they cause a problem in the normal functioning of the brain. Now the neuronal loss and brain atrophy. Significant loss of neurons and synapses, particularly in the hippocampus and cortex, and the resulting in brain atrophy, widening of sulci and ventricular enlargement. These are also the causes for the progression of this disease. And the last is cholinergic dysfunction. Decrease in acetylcholine levels due to the loss of cholinergic neuron in the basal forebrain. This contributes to the cognitive decline in memory loss. Uh, the neurotransmitter acetylcholine, it is the major neurotransmitter which is essential for memory and learning. When there will be the dysfunction or the loss of choline, it will lead to the Alzheimer disease. Now, clinical manifestation. Clinical manifestation symptoms of Alzheimer disease include majorly cognitive decline, behavioral changes, and functional impairments. Memory loss. In cognitive decline, there will be memory loss, especially short-term memory, difficulty in problem solving, planning, and performing familiar tasks, and disorientation to time and place. Behavioral changes include irritability and depression, social withdrawal and changes in personality, agitation and aggression in advanced stages. And functional impairments include a decline in activities of daily livings, difficulty in speaking, that is aphasia, understanding language and writing, poor judgment and decision making abilities. Now, should I continue?
Yes, you can continue.
Okay. Uh, Actually, the diagnostic part and treatment part is of Kotesh and he is not present.
Okay, I understand we are unable to connect to him. So if you would like to continue and if you would be able to present it, then you can carry on, or else we'll move on to the other topic.
No, no, I'll try to finish it.
Okay, thank you, Vadil. I think you can continue. Yeah.
Okay. Good. Uh, there are certain diagnostic parameters which includes clinical assessment, neuroimaging, laboratory test, and genetic testing. Detailed patient history and physical examination. In clinical assessment, there will be the detailed patient history and physical examination. Cognitive testing using tools like mini mental state examination or Montreal cognitive assessment. Neuroimaging includes MRI and positron emission tomography, that is PET scans to identify amyloid plaques and tau tangles. And laboratory tests include blood test and cerebrospinal fluid analysis to detect levels of amyloid beta proteins and tau proteins. Genetic testing includes the testing for the mutation in APP, PSEN1, PSEN2, which I already discussed, and apolipoprotein, that is APOE, to assess their risk, particularly APOE epsilon 4 allele. Prognosis, in prognosis, progressive decline. Alzheimer's disease is a progressive condition leading to gradual decline in cognitive and functional abilities. The rate of progression can vary widely among individuals. Stage of diseases. There are three stages of this disease: early stage, middle stage, and later stage. Mild memory loss, difficulty with complex tasks, and subtle changes in personality. In there will be increased memory loss, confusion, difficulty with language, and need for assistance with daily activities. In later stage, severe cognitive impairment, loss of ability to communicate, and complete dependence on caregivers. Expectancy, average life expectancy after diagnosis ranges from 3 to 10 years, though some individuals may live up to 20 years. There are also certain complications which include infections, malnutrition, physical injuries, which can shorten life expectancy. Quality of life will also be significantly affected, especially in the later stages of the disease. Supportive care and management of symptoms are crucial to maintaining the best possible quality of life. There will be also certain impact on families. The disease places a heavy emotional, physical, and financial burden on families and caregivers. Early planning for care and support services is essential to manage the long-term impact. Now the proper about MMSE and MOCA, that's the Montreal Cognitive Assessment. These are the diagnostic tools that are used for the diagnosis of Alzheimer's disease. MMSE, it is a 30-point questionnaire used extensively in clinical and research settings to measure cognitive impairment. Uh, there is range, uh, that is we can see 24 to 30 no cognitive impairment, 18 to 23 mild cognitive impairment, while when there is range from 0 to 17, there will be severe cognitive impairment. Uh, Cognitive impairment is just the normal reading, talking, walking, and learning processes that we use regularly. In cognitive impairment, the person will not be able to perform these tasks essentially or fully. MMSE, the usage is a quick assessment tool for screening and tracking cognitive decline. Now, Montreal Cognitive Assessment description is 30-point test designed to assist in the detection of mild cognitive impairment. It is majorly used for the detection of mild cognitive impairment. Range is 26 to 30 is normal. Below 26, it indicates cognitive impairment. Usage more sensitive than MMSE in detecting early stage of Alzheimer's disease. Clinical dementia rating. The scale used to quantify the severity of symptoms of dementia. Range is 0.5, 1, 2, 3, which include 0 include no dementia, 0.5 there will be very mild dementia, 1 will signify mild dementia, 2 moderate dementia, and when there will be 3, it signifies severe dementia. Usage of clinical dementia rating, used for staging the severity of dementia and is incomprehensive, including memory, orientation, judgment, problem solving, community affairs, homes and hobbies, and personal care. Uh, the other tool is Alzheimer's disease assessment scale, cognitive subscale. Description, a detailed assessment of cognitive function that covers a broad range of cognitive domains. Ranges scores higher score indicate greater cognitive impairment, maximum score of 70. Usage commonly used in clinical trial to measure the effectiveness of treatment on cognitive function. Now the treatment of Alzheimer disease include several drugs such as donepezil, rivastigmine, uh, galantamine, and memantine. Donizepil, donepezil, the dosage range is 5 to 10 microgram. Uh, the route will be oral, uh, taken at bed. Rivastigmine, 1.5 to 6 milligram mg. Frequency will be BD. Route oral taken with food. And the patch, rivastigmine patch, it will be applied to clean and dry skin or rotate sites. Glantamine extend release, that is 8 to 24 mg. That is there will be the uh, the effect of the drug will be for extended period taken with food, and it also comes in immediate release. uh, the dosage is 4 to 12 mg, and it is also taken with food. Mementamine, 5 to 20 mg. It can be given OD or BD, or oral route can be taken with or without food. Now, treatment algorithm for Alzheimer disease. First of all, there will be clinical assessment, a detailed and physical examination, and then cognitive testing. We that several tools will be used for the testing of the disease. Neuroimaging, laboratory test, and genetic testing will also be done for the confirmation of the disease. Now, particularly about the drugs, that is, first drug is donepezil. Contraindications will be hypersensitivity to donepezil or piperidine derivatives. Adverse drug reaction will be nausea, diarrhea, insomnia, muscle cramps, and fatigue. Precaution monitor for bradycardia, GI bleeding, asthma. Patient counseling. This drug should be administered at bedtime uh, and to decrease nausea. Severe side effects are to be reported to a healthcare provider. Rivastigmine, uh, adverse reaction will be nausea, vomiting, anorexia, dizziness, and weight loss. Precaution monitor for GI bleeding, seizure, and urinary obstruction. Now, rivastigmine and the patch, adverse drug reaction will be nausea, vomiting, anorexia, dizziness, weight loss. ADRs are just same for all the drugs. Uh, Precaution monitor, ADR and precaution are generally same for all the drugs. Patient counseling uh, taken with food to reduce GI side effects, report skin reactions. Memantine, contraindication, hypersensitivity to memantine. Adverse drug reaction will be dizziness, headache, constipation, confusion, and hypertension. Precaution, use caution in severe renal impairment and seizure disorder. Patient counseling may be given with or without food. Alcohol should be avoided. Report severe side effects to a healthcare provider. While taking memantine, alcohol should be avoided. Uh, and the non-pharmacological treatment, cognitive stimulation and memory training exercises, behavioral therapy to manage mood and behavioral changes. Supportive care is also provided to the patient. That is education and support for caregivers, uh, creating a safe and supportive environment for patient, planning for future care needs and legal considerations. Complications of Alzheimer's disease includes infections, falls and injuries, malnutrition and dehydration, pressure ulcers, behavioral and psychiatric issues, caregiver burden. Infection, Alzheimer disease, there will be chances of infection because there will be increased risk of pneumonia due to aspiration, and urinary tract infections are common, often due to incontinence and catheter use. Uh, Falls and injuries, gait disturbances and balance problem leading to frequent falls, increased risk of fractures and head injuries. Uh, Means when a person is having Alzheimer's disease, he is not able to walk properly, which can lead to frequent falls, and there will be chances of fractures and head injuries also. Malnutrition and dehydration. uh, Alzheimer, when a person is having Alzheimer disease, he is not able to eat properly, or or due to cognitive decline and physical impairment, and there will be weight loss and poor nutrition will be observed in that person patient. Pressure ulcer, immobility and incontinence can lead to pressure sores, requires careful monitoring and regular repositioning. Behavioral and psychiatric issues, aggression, agitation, and depression is seen in the Alzheimer patient, and increased risk of wandering and getting lost. Caregiver burden, emotional, physical, and financial strain on caregivers, high levels of stress and burnout among family members and professional caregivers. The prevention of the Alzheimer disease include healthy lifestyle, regular physical regular physical exercise can improve cardiovascular health and reduce the risk of Alzheimer's. Balanced diet should be taken, which will be rich in fruits, vegetables, whole grains, and lean proteins, which can support brain health. Mental stimulation, engaging in cognitive activities such as reading, puzzles, and learning new skill can help maintain brain function. Social engagement and maintaining strong social network is also beneficial. Control of chronic conditions. Uh, Alzheimer disease, as I have already told, the the cardiovascular factor can also lead to the progression of this disease. So the chronic conditions such as hypertension, diabetes, they need to be controlled to the prevent the occurrence of the Alzheimer disease. Regular medical checkups and adherence to prescribed treatments is also essential. Risk factors should be avoided, that is reducing exposure to smoking and excessive alcohol consumption can lower the risk. Protecting the head from injuries by wearing helmets and preventing falls, that is while riding we have to wear helmets so that if any accident occurs, the head should be protected, which can reduce the chance of getting Alzheimer disease. Yeah, the topic is complete.
Thank you, Badal. I think we can continue with the next topic,
Yes, yes.
Parkinsonism. So I request Nishita Arora to start sharing her screen and start with her presentation.
Hello everyone. Ma'am Safia will share the screen.
Okay, sure.
So hey everyone, I'm Nishtha and today we are going to discuss about Parkinson's disease. Mm, Next slide, please. So yeah, Parkinson's disease is a neurodegenerative condition resulting from loss of dopaminergic neurons in brain characterized by associated motor symptoms. So here neurodegenerative means a progressive or irreversible loss of neurons. And in Parkinson, it is mostly the loss of dopamine producing neurons or dopaminergic neurons in the substantia nigra, which will lead to the tremors or stiffness and difficulty in balance and coordination. Next slide, please. So yeah, if we talk about epidemiology, so it Parkinson disease roughly affects 1 or 2 people per thousand globally, and it is expanding more even. And the Parkinson prevalence increases significantly with age. So the biggest risk factor for developing this disease is advancing age, and the average age of this onset and the average age of onset is 60 years. So if we talk in case of gender, then men are more likely to develop Parkinson disease than women. However, the reasons are not clear for this, but some possible reasons may be occupational hazards or biological factors or genetics, etc. And the third factor of epidemiology is genetics. So individuals with parents or siblings who is affected have approximately 2 times more chance of developing the Parkinson disease. And an estimated 10 million people worldwide live with Parkinson disease. Next slide. So yeah, if we talk about etiology and the risk factors of Parkinson, the first and the most important point, and which is the case of most of the Parkinson patients, is the alpha synuclein and Lewy bodies. So these are the hallmark features of the Parkinson. Due to accumulation of these proteins, leads to the brain disruption of the brain functions, and particularly in substantia nigra, which is a crucial part of the dopamine production in the brain. Next is dopamine loss, which is the most common factor. And because we know that dopamine is a chemical messenger that controls the movement in the body, and in Parkinson, the dopaminergic neurons is related in the substantia nigra. They degenerate or they die, which leads to its deficiency, and the loss of dopamine is primarily responsible for the movement related symptoms of the Parkinson. So, third is genetics, and genetics play a significant role in Parkinson also, because around 10% of the cases are due to genetics. So there are some specific gene mutations occurs of the PARC genes or synuclein genes. So there is particularly mutations of these genes which may increase the risk of the developing the disease with a smaller effect size. And the fourth is environmental factors, which includes exposure to the certain toxins or environmental factors, which may be a risk factor, but the evidence is not conclusive, however. And the potential environmental factors includes pesticides, herbicides, and head injuries. So yeah, now we are going to talk about the pathophysiology. So if we focus on the flow chart at the right hand side, so it explains the destruction. It explains that the destruction of dopaminergic neuronal cells in the substantia nigra of the basal ganglia, it leads to the depletion of the dopamine stores. So dopamine stores are basically the vesicles of the axons, terminals of the axons of the dopaminergic neurons. So those are the dopamine stores, and which will lead to the degeneration of the dopaminergic nigrostrial pathway. So, nigrostrial pathway, we know that it is a dopaminergic connection in the brain. It is basically made up of bundle of dopamine neurons that project to the striatum, and striatum includes putamen and caudate and etc. So, the basic function of this pathway is to influence the motor or voluntary movement through the basal ganglia. So, there will be degeneration of this pathway, and which will lead to the imbalance of acetylcholine and dopamine neurotransmitters in the corpus striatum, and which will cause the impairment of the extrapyramidal tracts, which are controlling the complex body movement, and these will lead to the tremors, rigidity, and bradykinesia. The next important factor of pathophysiology is accumulation of Lewy bodies or alpha synuclein aggregates. Like alpha synuclein is a component of, of the Lewy bodies. So these molecules can form small repeated units known as oligomers or longer fibrils. So we'll not go in that deep. So according to some studies, there is a mounting evidence that indicates that these accumulations are toxic to the neurons, and they play a key role in Parkinson. There is one more factor which is not mentioned in this slide, and which is mitochondria. So we all know that mitochondria is a very much important organelle of our system, and when the when the function of mitochondria is completed, or when the mitochondria become old or damaged, so they are removed and replaced automatically. So in Parkinson, the recycling is disrupted, and which will lead to accumulation of dead mitochondria. So that is also an important factor of Parkinson disease. The next factor is genetics, and we studied like mutations of some genes like PARC gene or alpha synuclein gene or DJ gene. This will lead to the toxic environment and will automatically cause apoptosis of these cells. And the next are non-genetic inheritance, which includes oxidative stress or free radicals or environmental toxins, which will lead to the cell death. So these all factors collectively causes the bradykinesia, resting tremors, stiffness of cogwheel, postural instability. So these are the major symptoms of the Parkinson's disease. Next slide, please. So yeah, now we are going to talk about the diagnostic evaluation and modalities. So with this term, we know that diagnostic evaluation and modalities will consist of techniques or ways or tests that can be used to diagnose this abnormal or a particular condition of Parkinson. And firstly, it includes some signs and symptoms. So the major signs and symptoms, there is a mnemonic for that, and which is TRAP, TRAP, TRAP. T stands for tremors, R stands for rigidity, A stands for akinesia or bradykinesia, and P stands for postural instability. So postural instability means increased muscle tone or stiffness in the arms or legs. Like there is mild or severe stiffness in the arms or legs. First is tremors, and these are usually resting tremors. So there's going to be some shaking in the, for example, if we talk about hands, so those hands will be shaking. Next is rigidity. So there are two types of rigidity. First is in upper limbs, and in upper limbs, majorly there is cogwheel rigidity, like we studied, like it is mentioned in the pathophysiology slide. Cogwheel rigidity, which means if you roll your arm, you will hear a click click sound while moving it. So that is cogwheel rigidity, and that is majorly in upper limbs. Second is lower limbs. Second is rigidity in lower limbs, and that is majorly, which is you won't be able to move the lower limbs at all. Like you will need some assistive devices for that. So third, A stands for akinesia or bradykinesia. So these are totally different terms. Akinesia means no movement at all of anything, of any body part, and bradykinesia means struggle to cause any movement, or we can say struggle to initiate any kind of movement. So postural instability, like we talked about it, and the akinesia or bradykinesia, they both may lead to, we may have observed in patients, like sometimes these can cause emotionless face of the patient, or there are no face expressions. So, TRAP, tremors, rigidity, akinesia, bradykinesia, or postural instability. These are some major ones, or the big ones we can say, which we will be able to notice in the individual suffering from Parkinson. Next, there are some more symptoms. If we talk about motor symptoms, so these may include hypokinetic movements. Hypokinetic movements, and decreased manual dexterity, and Difficulty arising from the seated positions. Again, we talked about in bradykinesia, like the patient won't be able to initiate any kind of movement. So there will be difficulty arising from a seated position. Diminished arm swing during the ambulation. Dysarthria, slurred speech, dysphagia, difficulty with swallowing, fascinating gait, tendency to pass from a slow to quickened pace, flexed posture, freezing at the initiation of movement, and hypomimia, reduced facial animation, like we talked about it, hypophonia, reduced voice volume, and microphagia. Microphagia means small handwritings. So next is autonomic and sensory. One second. Yeah. Or autonomic and sensory symptoms. So here the patient experiences bladder dysfunction, constipation, diaphoresis, fatigue, olfactory impairment, orthostatic intolerance, pain, paresthesia, paroxysmal vascular flushing, seborrhea, sexual dysfunction, and sialorrhea, which means drooling. Next is mental status changes. Here the patient experiences anxiety, apathy, bradyphenia, which means slowness of the thought processes, cognitive impairment, on depression, and hallucinosis or psychosis. So these are all core-linked. And next is sleep disturbances. The patient will experience excessive daytime sleepiness because of insomnia, that is next factor, obstructive sleep apnea, and the rapid eye movement, which rapid eye movement we can relate it with psychosis, like we studied in second year of the family, and sleep behavior disorder. Next slide, please. So yeah, we are now going to talk about diagnosis and evaluation. So there are three basic factors of diagnosis or for evaluation of Parkinson. That is first and the foremost important is medical history. So medical history, your doctor will discuss your medical history in detail, because we talked like one of the major risk factor is genetics. So it is important for the doctor to record the medical history, and also not only for this purpose, but to uh, to detect the symptoms like tremors or postural problems the patient is suffering. So, to examine all those symptoms, including the onset or severity and progression of these symptoms. So, it is important to mark the medical history. Next is physical examination. So, assessing the motor skills and reflexes of the patient. And here the doctor will assess your reflexes, the muscle strength, coordination, balance, and posture. And he will also look for the signs of tremors, rigidity, and slowness of the movement. He will also evaluate your speech, cognitive function, and sensory abilities. Third, with third is which may not be used in all the cases, but additional tests, these are important for early diagnosis. So we can use these additional tests also, which includes dopamine transmitter scan. Here the brain imaging test. It is a kind of brain imaging test, and it is not a definite diagnostic tool for Parkinson. It will measure the dopamine transporter levels in the brain, which can be reduced in Parkinson disease. Second is MRI scan, and third is blood test. So we talked about the mitochondria thing, and these blood tests are used to measure the damage to the mitochondria. Next slide, please. So yeah, now we are going to talk about the treatment of the Parkinson. And so yeah, um, first is non-pharmacological treatment, and it includes physical therapy, speech therapy, and occupational therapy. So first is physical therapy. So physical therapy can improve the mobility, balance, and flexibility for those living with Parkinson's, and it includes exercises which focus on strengthening of muscles and improves the coordination. Second is speech therapy. Speech therapy can address issues with speech, swallowing, and communication that often develop in Parkinson. And the therapist work on techniques. For example, the best speech therapy at this time is LSVT, which stands for Lee Silverman Voice Treatment. So this is an example of the speech therapy, and the therapist work on these kind of techniques to improve the vocal strength and the clarity. Third is occupational therapy. So this therapy basically helps the patients to adapt to the daily living tasks, and this includes hand and arm therapy or bed mobility. Like patients can teach therapist can teach patients like how to move or how to get out of bed, etc. No, it can also include eating and drinking therapies. Like the therapist can help the patient for eating and drinking, and handwriting aids are also included, because we studied like microphagia is a symptom of Parkinson. Next, let's move forward to the treatment algorithm. So, after the diagnosis of the Parkinson disease, we'll identify the presence and the symptoms of the impairment. If there is one case, first we'll identify and manage the non-motor symptoms, and then will if there is no significant impairment, then we'll consider resalgilin. Next, if there is tremor and the patient is less than 65 years, or the patient is more than 65 years, in both the cases we'll consider carbidopa and levodopa. If there is bradykinesia or rigidity, if the patient is more than 65 years, then first we'll go for dopamine agonist, and then um, which is also levodopa, and then we'll go for carbidopa and levodopa combination. And if the patient is of the age more than or equal to 65 years, then we'll directly go for carbidopa levodopa. If the next case is of postural instability or gait impairment. So if the patient is more than 65 years, we'll go for dopamine agonist along with physical therapy. And if the patient is more than 65 years, we'll go for carbidopa levodopa along with physical therapy. Next, if there is development of motor complications, these complications we are going to study further. We then will opt for pharmacotherapy, and then we'll go for surgery or deep brain stimulation. So, if briefly we'll talk about deep brain stimulation, then it is basically it uses the electrical stimulation to treat the movement disorders and neuropsychiatric conditions. And it is often described as a pacemaker of brain, like it sends the electrical signals to the brain. Next slide, please. Now we'll discuss the pharmacological treatment. So first is anticholinergic drugs. It includes benztropine and trihexyphenidyl. So benztropine, the starting dose comes in range zero point 0.5 to 1 mg per day, which is maintained at in the range 1 to 6 mg per day. And the next is trihexyphenidyl, which is whose starting dose is 1 to 2 mg per day and is maintained at 6 to 15 mg per day. So anticholinergic drugs, it's clear by its can name, like anticholinergic, they'll block the acetylcholine activity, which will automatically reduce the tremors. And there's one more important thing about these anticholinergics. Like anticholinergics were the first drugs to treat the Parkinson disease. Next is carbidopa, levodopa products. Carbidopa, L-dopa, or secondly carbidopa or L-dopa ODT. So these both the starting dose for these both is in the range 100 to 300 mg per day, and it is maintained at 300 to 1000 mg per day. So here ODT, I guess I'll explain it. So ODT means orally disintegrating tablets. These will rapidly disintegrate on the tongue and does not require water to dissolve or swallow. So the third one is carbidopa or L-dopa CR. So the range For starting dose is 200 to 400 mg per day, and it is maintained at 400 to 1000 mg per day. So CR, I guess all know, like controlled release. Next is carbidopa or L-dopa or entacapone, which is maintained at the starting dose of 200 to 600 mg per day and be maintained at 600 to 1600 mg per day. Then again, carbidopa, whose starting dose is 25 and is maintained in the range 25 to 75 mg per day. Next are dopamine agonists. So these include drugs apomorphine, bromocriptine, uh, pramipexole ER, ropinirole XL, rotiglotine. So these are the drugs for dopamine agonist. Um, these all are in between the range from 1 to 3 mg per day. Um, Next class is COMT inhibitors, and these include drugs like entacapone or tolcapone. So entacapone, the starting dose is in the range of 200 to 600 mg per day, and it is maintained at 200 to 1600 mg per day. Next is tolcapone, which is whose starting dose is 300 mg per day, and it is maintained till 600. It maintained range is 300 to 600 mg per day. So these COMT inhibitors, we all know that COMT stands for catechol O methyl transferase enzyme. So this we have studied in patho in second year. Like COMT enzyme used to be present at the peripheral of the cell, and it is used to cause the degradation of levodopa before its entry. So these inhibitors prevent the peripheral degradation of levodopa. Next is MAO-B inhibitors. So these MAO-B inhibitors, originally MAO-B is an enzyme which absorbs the dopamine that brain isn't using. So these inhibitors block the MAO-B enzyme, and it is basically for the improvement of symptoms. So it includes drugs like salgilin, which whose starting dose is in range zero point 0.5 to 1 mg per day and maintained at zero point 0.5 to 1 mg per day. Next is cefagilin, whose starting dose is 5 to 10 mg per day and maintained at same dose. And next is salicylic ODT, which whose starting dose is 1.25 and maintained at 1.25 to 2.5. And miscellaneous is amantadine, whose starting dose is 100 and maintained at 200 to 300. So we know that amantadine MOA is a weak antagonist of NMDA type glutamate receptor. So it will increase the dopamine release and block the dopamine reuptake. Next, we'll talk about some monitoring of the potential adverse drug reactions of the drug therapy that we studied. Again, amantadine, it can lead to confusion or livedo reticulus, and we can in its monitoring parameters are mental status, renal function, lower extremity examination, or ankle edema. And one second. Yeah, sorry. Next is benchtrophin and triphenediol, and its ADR includes anticholinergic effects, confusion, and drowsiness. And the monitoring parameters are dry mouth, mental status, constipation, urinary retention, and vision. So we'll reduce the dose and avoid this in elderly or those patients that have already have the history of the constipation. Next is carbidopa, levodopa. It includes the ADRs like drowsiness, dyskinesis, and nausea. So the monitoring parameters for this is mental status, abnormal involuntary movements, and nausea, and will reduce the to improve this will reduce the dose or add amantadine or will take it with food, for example, non-protein snack. Next are COMT inhibitors, which includes entacapone, which can cause augmentation of levodopa side effects and can also cause diarrhea. Next is tolcapone, which will be same like augmentation of levodopa side effect or diarrhea, and it can also lead to liver toxicity. So to improve these this conditions, will reduce their dose, and we can give antidiarrheal agents, or we can monitor these symptoms for 2 to 4 weeks. Yeah, next slide, please. So now we'll talk about dopamine agonist. And first is apomorphine. It may lead to drowsiness or nausea or orthostatic hypotension, and we'll monitor it by mental status, nausea, blood pressure, dizziness upon standing. And so these are some drugs, and the common side ADRs of these are drowsiness and confusion and hallucinations. And now we'll there are some possible treatments for the symptoms also. I'll try to combine it together. Like some common symptoms are cognitive impairments or constipation. So for cognitive impairment, we'll eliminate the anticholinergic agents and add the cholinesterase inhibitors. So next, if there is a case of depression, then we can select the serotonin reuptake inhibitors. If there is drooling, then we can have give the local injection of botulinum toxin. If there is fatigue problems, then we can include caffeine or modafinil or proper nighttime sleep hygiene. If there is a falling complications like falls, then we can refer to physical therapies or assistive devices. If there are hallucinations or psychosis, then we can go for dose reduction or elimination of adjunctive medications, especially anticholinergic agents. So if there is pain, then we can treat it with for example, dystonic musculoskeletal neuropathic, and we can minimize the off times. We can refer to the orthopedics and physical therapy and or pain specialist also. So next slide, please. So now there are complications which are very much common due to the drug therapy or other factors. First is speech and swallowing difficulties, which may lead to slurred speech or difficulty swallowing or increased risk of choking, and it is all due to the muscles that are involved in speaking. Next is swallowing problems. Again, it can lead to aspiration pneumonia, which is a serious condition where food or fluids enter the lungs. Next is cognitive decline and dementia. It can develop in the later stages of the Parkinson. And the most common complication is depression and anxiety. And then sleep problems, obviously, restless leg syndrome, difficulty falling asleep, staying asleep, and frequent walking during the night can disrupt the sleep patterns and worsen the other symptoms. Next is urinary problems, constipation, pain. Muscle stiffness, rigidity, and cramps can cause chronic pain throughout the body. And some complications are also they also deal with skin problems like difficulty sweating and changes in skin oils. It can lead to dryness, itching, and increased risk of the skin infections. Next is blood pressure fluctuations are also there, and the most important is falls, like balance problems and impaired coordination and freezing of the gait, like sudden inability to move. These can significantly increase the risk of falls, which can lead to serious injury. Next slide. So yeah, now we are going to talk about the pharmacist interventions. So in brief, the pharmacist will review and adherence. Pharmacist can and assess the patient medications for the interaction and educate the patient about their medications and side effects and how to manage them. And optimizing therapy, they can collaborate with doctors to optimize the medication regimens. Next is addressing the medication related problems like side effects and non adherence concerns. Next is patient care and support, disease education, like Pharmacists can provide patients with educational resources about the Parkinson disease, including its symptoms, treatment options, and how to manage it effectively. Next is communication and support. Like there should be a good communication between the pharmacist and the patients. Like patient can ask any question or query he has for the disease. Next is referral. In some cases, pharmacists can refer patients to healthcare professionals like neurologists or physical therapists for further management. Next slide, please. Last but not the least, we're going to talk about the potential areas of further research. Now, this is interesting. Like it includes disease modifications, which include targeting the alpha synuclein aggregation. Like in patho, we studied like there is going to be formation of aggregates of alpha synuclein. So we are going to we can target um, we can do some research that can target these this aggregation, like understanding how these clumps are formed and developing strategies to prevent this accumulation. Next is neuroprotective therapies. So protecting the dopamine producing neurons from degeneration is another crucial research area. And because we know like there is no current treatment that slows the neurodegeneration, like there is no current treatment ever, so we can work in that kind of field. Next is early diagnosis and biomarkers. It includes blood tests, like we talked about mitochondria condition, like a simple blood test can detect the Parkinson's, like for early diagnosis for damage of the um, which can include damage of the mitochondria or etc. And the next is imaging biomarkers, which includes developing more advanced imaging techniques to detect the early signs of the alpha synuclein accumulation in the brain. So it is another area of interest. Next are advanced treatments. So we know like current medications can lose effectiveness over time, and some patients experience side effects also. So scientists are exploring new therapeutic approaches like gene therapies, techniques to introduce healthy genes or silence faulty genes that contribute to the Parkinson's are being investigated. Next is stem cell therapy, replacing the lost dopamine neurons with the healthy stem cells that holds the future treatment for the disease. Next is deep brain stimulation advancements. So deep brain stimulation is no doubt used, but its advancements like refining the DBS techniques and exploring its use in combination with other therapies or ongoing areas of research. Like we can combine it with the therapy, pharmacotherapy. So that's all for the therapeutic presentation of the disease. Now Safia will present the case presentation on this. Thank you.
Good evening. Just a confirmation, can you hear me?
Yes, Safia.
Okay, so I'm Safia Anhar, and today I'm going to present a case on Parkinsonism that is secondary to Wilson's disease. Wilson's disease is an autosomal recessive disorder of copper metabolism that is characterized by impaired biliary excretion of copper, which leads to its accumulation in various organs, including liver, cornea, and brain. It is also known as hepatolenticular degeneration. Copper is an essential nutrient which is involved in various physiological processes, including the melanin biosynthesis, dopamine metabolism, and iron hemostasis. It was first described by Samuel Kinner Wilson, and it arises due to mutations in the copper transporting gene, that is ATP7B, which is located on human chromosome 13. These mutations will further lead to impaired copper transport and its subsequent accumulation in the body. And coming to the signs and symptoms, it presents with liver disease symptoms like hepatosplenomegaly. Then it has some neurologic symptoms, and also the key feature is the presence of Kaiser-Fleischer or KF rings.
And since it has diverse clinical manifestations, it has also been referred as the Great Masquerader. The biochemical findings include decreased serum ceruloplasmin level and increased urinary excretion of copper. The standard management includes chelating drugs that includes penicillamine and trinitrin dihydrochloride, also zinc supplementation and liver transplant. Coming to Parkinson's disease, it is a degenerative brain disorder that causes unintended or uncontrollable movements, and symptoms usually begin gradually and worsen over time. We have seen this, the pathophysiology, signs and symptoms and management was explained by Nishchita. So I'll move on with the case. We have a case of 10 years old female patient who was brought with chief complaints of inappropriate laughter and slowness in daily activities. The parents also reported a progressive onset of symptoms over past 2 months, which included worsening of tremors and rigidity. She had no past known medical history, and also there was no known family history of movement disorders or any similar complaints. Coming to the objective evidences, the vital signs of patients were normal, pulse rate 120 beats per minute, BP was found to be 110/70 mmHg, and she was afebrile. On physical examination, we found that she was conscious but irritable, and examinations of serious respiratory and per abdomen were normal. Neurological examination revealed she had cogwheel rigidity and resting tremors, hypomania, which is mask space, and dystonic movements affecting neck and upper limbs. Then ocular examination using slit lamp was done to confirm the presence of Kessler-Fleischer rings, that is KF rings, which is like golden brown pigmented rings, as you can see in the picture, around the cornea, which results due to copper accumulation. It appears to encircle the cornea, overlaying the iris, and it is a typical symptom of Wilson's disease. The brain MRI was done to assess the extent of neurological involvement, and it revealed hyperintensities in basal ganglia on T2-wave images, which indicate the areas of copper accumulation. And it is also a hallmark feature of Wilson's disease that affects the central nervous system. Coming to the laboratory investigations, we found that there was low level of serum ceruloplasmin, which is a copper binding protein essential for copper transport in body. And also 24 hours urinary copper excretion was significantly elevated, which is consistent with the diagnosis of Wilson's disease. So based on these subjective and objective evidences, the patient was diagnosed with Parkinsonism secondary to Wilson's disease. The plan included goals of therapy was to lower the excess copper in the body to prevent further damage to the liver and other organs, elevate the neurological and psychiatric symptoms such as tremors, rigidity, bradykinesia, dystonia, and inappropriate laughter, slow the progression of disease to avoid any long-term complications, and also to improve patients' overall well-being and ability to perform the daily activities. Regular monitoring of liver function tests, of neurological symptoms to assess the response to the treatment, and also copper levels in blood and urine should be done. So coming to the treatment, we started her with tabpactine, that is trihexyphenidyl, that is a central anticholinergic drug with a dose of 2 mg once daily. Then she was given with vitamin supplementation twice daily, and also tab-combifis, that is a combination of ascorbic acid and zinc supplementation at night. Then with this, the patient, we saw that there was the improvement in symptoms, and patient was discharged after 5 days with a comprehensive follow-up plan and discharge medications. The discharge medication included trihexyphenidyl and tabcombrifis, that is combination of ascorbic acid and zinc. Coming to patient counseling, Wilson's disease is a rare genetic disorder that prevents the body from getting rid of extra copper. Normally, copper is processed by liver and is excreted through bile. But in Wilson's disease, this copper builds up in the liver, brain, and other organs. And Parkinson's disease is a movement disorder, as we have seen, and it causes unintended or uncontrollable movements such as shaking, stiffness, imbalance, and difficulty in coordination. About drugs, do not skip any dose. If you miss any dose, then take it as soon as you remember. But if it's almost time for next dose, do not double the dose. And also report to doctor immediately if any allergic reaction occurs. This is what patient was advised. Coming to lifestyle modifications, the patient was advised to avoid foods that are high in copper, such as liver, shellfish, nuts, chocolate, and mushrooms. And she was asked to eat a balanced diet with plenty of fruits, vegetables, and whole grains. She was asked to come for regular follow-ups with the doctor and explained that these follow-ups are crucial to monitor the copper levels and also for the effectiveness of the treatment. Then she was advised to engage in moderate physical activities like walking or swimming, as these activities can improve the overall health and reduce her muscle stiffness. She was also asked to take the medications exactly as prescribed, not to skip any doses, and be consistent with these medications, as these medications are a key in managing Wilson's disease. And also, she was asked to drink plenty of water to help flush out excess copper from the body. So this case has an atypical presentation of Parkinsonism in a 10-year-old patient. While the disease, Wilson's disease, typically presents with hepatic and neurologic symptoms in pediatric patients, the occurrence of Parkinson's disease is very rare. So this highlights the importance of considering Wilson's disease as a possible etiology in young patients who present with movement disorders. Thank you.